There are no two ways about it. Being diagnosed with cancer is hard, very hard. Today, we're talking about prostate cancer, which, by the way, is 99% curable if caught early before it spreads. And we're going to answer all your questions next on Dr. Q&A. Welcome everyone to Dr. Q&A. I'm Olga Villaverde, and joining me today is Dr. Michael Poch. He is a urologist and an associate member at Moffitt Cancer Center in Tampa, Florida. Thank you so much for joining us today on Dr. Q&A, sir.
Thank you very much, Olga. I appreciate the opportunity to educate your viewers.
And we appreciate your education towards us. So before we get started, Doctor, I do want to remind our viewers that if you do have a question for our expert, it's so easy to get in touch with us and send those questions in. All you have to do is email the questions to questions@allhealthtv.com or just call us 855-796-4475. You can also record your question on your cell phone and upload it to us on our website, which is right there, allhealthtv.com. So doctor, since I said uploading a video question, we have one from Nargis. Let's see what he's asking.
I'd like to know, what are the first warning signs of prostate cancer?
And I'm so sorry, Nargis. I said he, but it is a she. And that's a great question. What are the warning signs, doctor?
Thank you, Nargis. Great question. Unfortunately, there aren't a ton of warning signs for prostate cancer, which is why we use the PSA blood test for screening for prostate cancer, as well as digital rectal exams. So typically when men come to the office, they say, I feel perfectly fine. I've got no symptoms whatsoever. And unfortunately, early prostate cancer doesn't present with a lot of symptoms. And so it's up to us to try to navigate in and around that challenge.
All right. And doctor, I want to backtrack a little bit. Let's just kind of do the prostate 101. Tell us what the prostate is, where is it located, and what's its job? A few questions there.
Sure. So the prostate's part of the male reproductive system. It's a small walnut-sized organ that sits between the bladder and the penis. When men pee, the urine starts in the bladder. That pee goes through the center of the prostate, down the urethra, and out the tip of the prostate, or out the tip of the penis. Sorry. The prostate makes prostatic fluid, which helps nurture the sperm during ejaculation, and PSA, which is a prime ingredient of that prostatic fluid, actually helps that sperm make its way all the way to the egg for fertilization.
And doctor, go ahead.
I was saying typically that prostate also sits right in front of the rectum. So during digital rectal examinations, that's how the urologists are able to feel the prostate to do an appropriate exam.
And doctor, at what age should someone start getting screened in terms of prostate cancer? What is the age today?
Sure, it's a little bit controversial. Over the years, at least the last 2 decades, there's been some controversy about the perfect age when men should get screened. Moffitt Cancer Center is part of the NCI, or is an NCI designated hospital, and typically we follow what we call the National Comprehensive Cancer Center Guidelines, or the NCCN Network Guidelines. And those guidelines recommend starting PSA screening and prostate cancer screening at age 45 for men without risk factors. Typically, if you've got a low PSA and a normal prostate exam at that time, then you can go to every other year screening if that PSA is under 1. If the PSA is between 1 and 3, then typically we recommend annual screening with PSA and prostate exams. There are some certain groups that have higher risk factors for prostate cancer, and we typically recommend earlier screening for those folks.
I have some follow-up questions to all that. You mentioned the word controversy. Why is there? What is it?
Well, there are some studies. A while back, the USPSTF, the United States Preventive Task Force Services, kind of downgraded PSA screening because there was some longitudinal studies to suggest that it wasn't as helpful as people initially thought. There's a lot of urologists that feel that that's not necessarily the case, and a lot of studies to support the use of PSA screening in populations of men. And over the past decade, when we've seen PSA screening going down because of these recommendations, we've actually seen the incidence of prostate cancer going up.
And doctor, you mentioned a few seconds ago risk factors. Can we talk about those risk factors? And is it an assumption to think that all men are at risk for prostate cancer?
So all men are at risk for prostate cancer, but there are some categories of people that are at higher risk for developing prostate cancer. those men that have a first-degree relative with prostate cancer are at our higher risk for developing prostate cancer. African Americans are at high risk for developing prostate cancer and higher grade prostate cancer. And there are some genetic mutations that are associated with prostate cancer. If you think about breast cancer, you think about the BRCA mutations for breast cancer. Those are also associated with prostate cancer risk. And so if men are young enough when they're diagnosed, we typically will also screen for BRCA genetic changes, and or if they've got family members with a strong family history of BRCA-related or BRCA-related diseases, then we'll also start to screen those patients earlier as well.
And doctor, you mentioned African American men are more likely to get prostate cancer. Do we know why?
We don't know why for certain, and there's actually a stronger body of literature over the past 5 to 6 years to suggest that the social determinants of healthcare play a stronger role than we thought in some of that disparity between African American and Caucasian men developing prostate cancer. So access to healthcare is a pretty important risk factor in terms of the age of diagnosis and the timing of diagnosis and the grade of diagnosis. And so that there's some subtleties associated with those differences which haven't really been figured out yet entirely. But the answer is we don't know exactly what those genetic differences are also that may be at risk.
And doctor, how do you diagnose prostate cancer?
Prostate cancer is typically diagnosed with a prostate biopsy after you have a suspicious either exam or suspicious PSA test. Then you move on to do a biopsy. And the biopsy can be either done in the office or it can be done in the operating room. When it's done in the office, traditionally it's done with an ultrasound probe that goes up the rectum. The prostate gets numbed, and then we typically will sample the prostate either between 12 and 16 times, depending upon how risky that patient is. Or if it's done in the operating room, typically the patient's put to sleep, and the prostate biopsy is done through the skin between the anus and where the scrotum is. That area we call the perineum. So that's called a perineal prostate biopsy.
Now, when men hear all this, is it difficult to get them into the office to perform these things or perform these screenings? Because we know how it can be. I'm being PC about that.
Well, once they've, it's once they're part of our job as physicians, I think, is to create that environment where they feel like they can have those conversations about their risk, where they can speak freely, where they can explain what their apprehension is, either about doing PSA screening or about doing prostate biopsies. Anything we do in medicine is associated with risk. And so it's our job to navigate that risk and also explain why things are the way they are in terms of risk versus not risk, and kind of weigh the balance there.
And doctor, is the PSA level always accurate, or is it sometimes necessary to kind of do a repeat, if you will?
We typically recommend repeat if there's a suspicious level. That being said, years ago when I was training, the PSA cutoff used to be 4 as an indication to do a prostate biopsy. And these days, there's no, quote, normal PSA. PSA can be elevated for a number of reasons. It can be elevated for prostate cancer, but it can also be elevated for prostate infection, or it can be elevated because of benign growth or normal aging male growth of the prostate. So there's 3 main causes of elevation of that PSA test. So it's always important to repeat, and it's always important to have that discussion with your urologist about how risky it is to have prostate cancer versus those other 2 potential diagnoses.
And I asked that because my uncle's very healthy, and I believe he's 81. My guess is 81, 82. And his numbers are always elevated. We talk about that. And he gets checked and everything is fine, but it's always an alarming thing to see for him.
For sure. And again, obviously it depends on what his numbers are and what his trend is. Typically, we don't like to use one number all by itself. So if you've got a high number, but that number is stable, that's more reassuring than a number that is continuing to go up on the rise. The other thing to know is that typically if you're diagnosed with prostate cancer after the age of 80, with a stable PSA, it's got a very low likelihood of being a cause of mortality. And most of the screening guidelines recommending to stop PSA screening in and around between the ages of 70 and 75, depending upon how healthy the patient is.
Doctor, I got a question here from Patrick, and he's asking, is it a warning sign when bleeding going to the bathroom? Your response?
So it's never normal to have blood when you urinate. There's a number of different reasons that could cause that, though. And typically, blood that you can see in the toilet necessitates a workup, and that workup should be a scope of the bladder to look inside to make sure that there's nothing going on inside the bladder or the urethra. And you typically need some imaging of the kidneys. There's any number of diagnoses of the kidneys that can cause blood in the urine as well as kidney stones. So you probably need a thorough evaluation because it's never normal to have blood in the toilet when you pee.
And what about if you're going, let's say, number 2 and not number 1?
Again, typically not normal to have blood when you're defecating, and that also needs to be worked up by a physician. Usually that's done with a scope or colonoscopy. And again, there's certain guidelines for routine colonoscopy as well.
All right. I want to go to this video because it's very cute to watch. Researchers are working on another way, apparently, to diagnose prostate cancer, and they're using cute dogs. This is a short video. Take a look.
Remember the tricorder? That all-powerful scanning device that identified everything from poisonous strawberries to alien life forms?
There it is. Pure tritanium.
We all know the cell phone in your pocket is getting close to tricorder-like greatness. But one thing is missing. It can't smell. The Prostate Cancer Foundation, in collaboration with Johns Hopkins University, MIT, and Britain's medical detection dogs, aims to change that. Newly published data proves, without a doubt, that dogs can smell prostate cancer. Now we're going to build a robotic nose to sniff out prostate cancer and put it in your phone. This is step 1 to get us there.
Okay, so nothing surprises me anymore. That's just amazing. Have you heard of that? And your thoughts, doctor?
I've actually seen the study, and as a dog lover,
Really?
I think that's awesome. There's obviously a lot that we don't know in the world, and if we can use our furry little friends to help us out diagnosing prostate cancer, that's great. Based upon the studies, they're pretty accurate at doing it. So obviously, this is an initial step at trying to figure this all out. But I think the more power we have in our hands in order to diagnose prostate cancer, the better we'll be for it.
Absolutely. I completely agree. And I'm a dog lover too. So there you go. Doctor, are there different types of biopsies? You talked about it. Are there different types or is it just one?
There's the standard 2 biopsies are the ones that I spoke about. The one that's done in the office, typically done with a probe that goes in the rectum, and then the biopsy needles go through the rectal wall. The other ones are the ones that are done in the operating room, typically done in the space between the anus and the scrotum, called the perineum, where the needle goes directly through the skin rather than through the rectal wall. That's typically obviously a little bit more uncomfortable if you're poking holes directly through the skin, and therefore that's why we usually put patients to sleep for that.
I concur. Before we continue, Doctor, I just want to remind our viewers that if you have a question for our expert, please, send us your question and we'll have him answer it, or her, of course. The email is questions@allhealthtv.com. You can call us 855-796-4475, or you can use your cell phone, upload a video of yourself with your question, and go to our website right there, allhealthtv.com. Speaking of video question, Doctor, I have one this time from Beth. Let's see what she writes or she says.
Hi, my name is Beth Lagan, and I have some questions regarding prostate cancer. In the instance somebody is diagnosed with prostate cancer, does the prostate always have to be removed? And if so, is it possible for that person to still be intimate? Or are there different types of procedures for the prostate when you're diagnosed with cancer, depending on the stage?
All right, several questions there from Beth. That was fantastic. I really appreciate those questions, Beth. Let's go with the first one, Doctor. I wrote it down. Does the prostate always have to be removed?
Absolutely not. So it really depends on the stage and the grade of cancer. So that's the first thing we usually do when we evaluate prostate cancer is we grade the cancer, we stage the cancer. So for patients that have localized cancer, meaning cancer that's just in the prostate and it's low grade, meaning not very aggressive, a lot of times what we'll do is we'll watch that prostate cancer because patients are more likely to have cardiac events, stroke events, et cetera, that are the cause of their mortality or morbidity down the road. And so we call that strategy active surveillance, where patients get routine PSA tests, they get routine prostate exams. A lot of times they'll get additional imaging, MRIs of the prostate to evaluate those tumors to see if there's change. And frequently they'll get repeat biopsies every 1 to 2 years, again, to see if there's physical change on the needle biopsy. So prostate cancers don't necessarily always have to be removed. In addition, prostate cancers that we want to treat can be treated with things other than surgery. Most commonly would be radiation treatment, which can be radioactive seeds or external beam radiation treatment.
Okay, doctor, her question number 2 was, and I'm sure you get this question all the time. She was wondering if it's possible to have intimacy after prostate surgery. I'm sure all the men and partners and wives ask you that constantly.
Sure. I mean, this is sounds like a day in the life of my clinic, which I usually do on Mondays. So yeah, it's very possible to be intimate after surgery. So the 2 main side effects of surgery, the first is urinary incontinence, meaning that men are unable to hold their urine. And that's something that usually gets better after surgery, but it can take weeks to months and even up to a year to recover. The second is the sexual function can be affected. The nerves that provide the ability for the penis to become erect sit on top of the prostate. And so when we do surgery, sometimes we need to remove the nerves with the prostate, but sometimes we can leave those nerves. So if you can leave both nerves intact and just remove the prostate by itself, then you're more likely to have a good outcome in terms of your sexual function. If unfortunately you've got aggressive prostate cancer and those nerves need to be removed, then that can affect the sexual function down the road.
Now, I'm sure when you explain this to them, they're asking for guarantees here, and there's no guarantees, but it looks hopeful, right?
It does look hopeful, but again, it really depends on what the pathology is. So again, if you say, well, we need to remove both nerves, then you can almost guarantee that that's going to be a bad outcome in terms of sexual function. If, on the other hand, you can say, well, we're going to spare both of those nerves, leave them inside, then patients are much more likely to have good sexual function after surgery. That being said, a lot of our patients actually come in with what most people consider some ED, and therefore we also have to navigate in and around that issue in terms of saying, well, what are your expectations after the surgery? If you come in with some ED, we're certainly not going to make that better at the same time.
Okay, I have a few more questions before I get to Beth's final question. Is this robotic surgery, and how is sexual function then restored after?
So most of the surgery that's done in the United States for prostate cancer is done robotically these days, which is robotic laparoscopic surgery. So anytime you enter into the abdominal cavity and you pump it full of gas in order to create space, we call that laparoscopy, similar to how appendix, gallbladders, colons are removed these days. Then we attach a surgical robot to the ports, and we control the robot from a bedside console in order to do the operation. There are some centers where the operation is still done open, but increasingly surgeons are moving over to the robotic platform to do that operation. In terms of recovery, the recovery from the robotic operation is great. Most patients stay the night in the hospital, go home the next day, usually going home with a catheter in their bladder. That catheter gets removed after about 2 weeks. In terms of sexual function, at that follow-up appointment is typically when we discuss recovery of sexual function, usually starting with some medications, but it can take a little bit of time for that to recover as well.
And doctor, times are different. I mean, I think people are communicating more, which is such a blessing. Do men come in and discuss the issues maybe they're having after the surgery? Is it kind of like a partnership with, the partner coming in or the wife, and the wife speaks for them? In other words, communication better today?
I think it's better today. I mean, everybody has their own certain set of circumstances that they come in with. I think one of the challenges that we've had during the past 18 months is that there's been certain restrictions on family members coming into visits all across the nation.
Yes.
And so having that discussion with all the family member that's appropriate, or that family unit that's appropriate, has been really, really hard. Setting expectations, going over side effects, risk factors, et cetera, has been exceedingly challenging, particularly around some of these sensitive topics. But I think, again, I think that the physician's job in this scenario is to make people feel comfortable enough that they can open up and have a free discussion about some of those things.
And speaking of comfort and hope, I want to share with our viewers an inspiring story from a prostate cancer patient. It's a short video. Take a look.
I've always been very healthy. I've always been for me, it's always been about mind, body, and soul, right? It's all combined together. When I first found out that I had prostate cancer, I remember like it was yesterday, the exact thought that I had. And that was, I want to be here for my family. And I am not going to miss my daughter's college graduation. I turned it right around and said, listen, this is going to give me a really good reason to stay positive and fight. And I think that if we're positive, we're going to get more healthy. And if we're fighting something, it's going to help us fight it and win. For me, it's been 2.5+ years, and I've been on this journey from discovery to treatment. I ended treatment at the end of the year 2019, so I'm doing amazingly well. I would say that I'm in remission. My own clinical trial was funded by Prostate Cancer Foundation. Prostate Cancer Foundation probably saved my life.
Oh, Pat, thank you so much for that story. And by the way, the Prostate Cancer Foundation is dedicated to funding life-saving cancer research. So to find out more, we'd like to share with you this website. It's right there, right under me, pcf.org. That's pcf.org. Please check it out. Doctor, we have a viewer question from Michael. Why don't we take that and see what he wants to know, and I'll read it to you. Do certain spices, garlic or cannabis products, help in the fight against prostate cancer? Great question there, Michael. Thank you. Doctor?
Yeah, thanks, Michael. That is also a great question. That also comes up very frequently in the clinic. Patients want to be proactive in their care. They don't want to just step aside and say, okay, you do all the work. And just like our video presenter as well, Pat, they want to take a little bit of initiative in this. Unfortunately, there's not a lot of studies to support some of the naturopathic remedies or naturopathic medicines that people want to try. I know actually, at least for CBD oil, there's been some lab studies to suggest that it does have some anti-cancer effects. And hopefully over the next decade or so, we'll see some studies come out which will hopefully support this, because we'd love to have something to give to our patients to be able to do while we're doing the standard care, so that they can help either decrease their risk or increase their prevention of prostate cancer.
Absolutely. Just a reminder to our viewers, if you want to send in a question to our expert, it's so easy to do. You can email, phone, or just check out the information. Questions@allhealthtv.com. There you can send your question or call us 855-796-4475. Upload a video of yourself with your cell phone right there at our website, allhealthtv.com. Doctor, exercise, diet, we always talk about things. We have a few minutes left in the show. It would be a sin if I did not bring it up. So does that help at all in avoiding things like prostate cancer?
Sure. So the answer is that we know from some studies that if you have a diet that's low in animal fat and high in vegetables, that actually does decrease your risk of prostate cancer. What I usually tell my patients is that the healthier you are, the healthier you be. So if you practice a healthier lifestyle, that you'll be better all around in terms of your physical health, and that'll do better for you. But specifically related to prostate cancer, we know that low animal fat, high vegetable diets are the best.
I have a viewer question from actually a friend of mine who I'm not going to mention her name, but we've only got like 2 minutes, doctor, but I want to get it in. And she says, my husband goes to the bathroom every night 3 to 4 times an evening. Is that a problem?
Well, I would say it's a problem if the patient or if her husband is annoyed by the fact that he's waking up. Typically, that frequency of urination at nighttime, we call that in the medical jargon, we call that nocturia. If you're doing it 3 to 4 times a night, typically that's impeding your sleep. And so that's probably something that should be evaluated. And it's hard to know what that is. Typically, or most commonly, what we see as urologists is that benign prostate growth. As men get older, prostate gets bigger, it impedes the urinary flow. So it either decreases your emptying or decreases that ability for that bladder to get a good squeeze to get all the urine out. But there's some other reasons for patients to have nocturia, especially that many times per night. So it certainly needs to be evaluated by a urologist, particularly if it's bothersome to the patient.
And doctor, as we wrap up this amazing segment with you, any final advice? And could you repeat one more time when screening should be done? Because I think it's always important to reiterate that.
Sure. So I think it's important to know that not all men will present with symptoms with prostate cancer. So it's always important to do that screening. I guess that would be my take-home message. And that screening for patients without risk factors should be at age 45 with a PSA as well as a digital rectal exam. For patients with risk factors, African Americans, family history that's significant with a first-degree relative, or BRCA or BRCA mutations, or any germline mutations that are associated with prostate cancer should start at age 40. And you can ask your physician about those.
Thank you so much for your time, doctor. I do appreciate it very much and all the information you gave us.
All right, thank you very much. I appreciate the opportunity.
And that's all the time we have today for Dr. Q&A. I'm Olga Villaverde, and we hope to see you next time. You take care.
The Health Channel wants you to have all the answers you need to be in control of your health.
Infection and the virus keeps coming back.
That's why, in addition to Dr. Q&A,
if treated appropriately, the patient should...
you can always chat with one of our health advisors through our free service, Ask Hannah. Just go to allhealthtv.com or download the Health Channel app and get the answers you need.
No question should ever be left unanswered. Remember, if you don't know where to start, ask Hannah.